Good morning. That'll wake you up. Thank you for joining our session today, Challenging Case Competition, Coronary Semifinals 1. We have a tight schedule, 10 minutes per lecture. We may go a little bit out of order this morning as some individuals are still uploading their presentation. So when you come up here, you'll see a timer. If you can just please stick with the time frame. We have a great panel and a co-moderator. I'm Dean Medulas. I'm from Columbus, Ohio State. And it's a pleasure to be here. And I'm just going to turn this over to my co-moderator here to introduce herself, and then we'll just go down the panel if you guys introduce yourselves as well. Thank you.
Good morning. My name's Rayanne Davies. I'm based out of Wellspan in York, Pennsylvania. It's nice to see you all today.
Good morning. I'm Sam Mehta, and I'm based out of Denver.
Good morning. Cihan Çevik from UC Health Memorial, Colorado Springs.
Good morning, Twee Pham from Plano, Texas, Baylor Scott White Heart Hospital.
Okay, I have to get used to this. I'm Jacqueline Tamis-Hollnad from the Cleveland Clinic.
Okay, we're going to start, and let's see if our, okay, you want 2 seconds? Sure. So what we'll try is it's 10 minutes, if the lecturers can finish with a couple minutes to spare, or we can have a discussion here with the panel and any interesting topics or points to make, or even during your presentation. If you have a stopping point, please feel free to stop for 1 or 2 minutes, but we'll try to keep within the 10-minute limit. Thank you. So it looks like our first presenters here. Dr. Vasileios Bolis is with us all the way from Greece, is that correct? I hope you had a safe and no delay trip.
Okay. Okay, thank you. Great. Point here. Okay. Good morning, everyone. I want to thank the committee for my presence in this great meeting. And I'm coming just from Greece. I'm here to present a case about our beloved COVID-19. So the patient is a young patient, a 30-year-old male, with a free medical history and a family history. He's a current smoker. He mentions that a few days ago he was vaccinated with a COVID-19 vaccine. He's presenting in the ER with chest pain and elevated cardiac enzymes, with a normal ECG and a normal echocardiogram. We proceeded with a coronary angiography. The left left anterior descending artery was a normal one with a healthy male. The circumflex artery was also fine. However, the right coronary artery was totally occluded. This actually caught us by surprise. We performed an OCT. We found no thrombotic plaque, no plaque rupture. However, a high amount of thrombus inside the artery. So we have a young patient with no risk factors and normal arteries with no atherosclerotic disease, but a high thrombus total occlusion. The only lead we had for this patient for why this happened was the vaccination of COVID-19. Back in the golden era of the vaccines of COVID-19, when all these studies took place, it was found that DNA-based vaccines for COVID-19 had a higher incidence of myocardial infarction. And this includes all ages, even younger ones, patients who have no atherosclerotic disease. there have been proposed three major pathological mechanisms. One of these is an allergic reaction to the vaccine. The other one is in older adults who have coronary disease and have demand ischemia because of the vaccination. And the major pathological mechanism is a generalized inflammatory response that leads to coagulation disorders, including many pathways, many anastomosis pathways. The first studies suggested that this coagulation disorder is because of thrombocytopenia, but this is not actually the case. Platelets can be normal or not. And what about the other tip of the scale? Well, the COVID-19 infection itself is a major hypercoagulation state, where we found that the risk of myocardial infarction after a few days of COVID-19 infection is very high. So what about our case? We proceeded with a PCI to the right coronary artery with a great result, and we also tested the patient for thrombophilia, but the genes were negative. So what do we learn about this case? Are vaccines bad? No, this is not the case. The case that the risk of COVID-19, even if it's not in its former glory, is still a global threat. And vaccines are really the cornerstone of dealing with this disease. There are many benefits that overcome the possible risks. But however, we have to be aware that of every possible side effect because vaccination is on such a large scale. So myocardial infarction due to coronary artery thrombosis is a potential complication, even rare, and we have to be aware of this. And we have to even though the most vaccines that are responsible for this are the DNA-based vaccines. However, we have to study what's happening about the other vaccines that are the RNA-based and not DNA-based. And also, what is the best way to deal with this thrombosis? Is stenting the best option? Or is it like what we did? Or is a better option for these patients, especially when the patient is young, like our patient, and he has no traumatic disease? And finally, the local inflammation and coagulation disorder is the main proposed mechanism of this thrombosis in the coronary arteries. Thank you very much.
Thank you for presenting that excellent case, very interesting. And just to turn it over to the panel, to get some thoughts, how would you approach this patient? OCT showed heavy thrombus burden without plaque rupture. What were your guys' approach in the cath lab?
I would do 2B3A antagonists and definitely imaging with OCT.
Even though it is totally occluded, you will go. That's a real question about the best option of these patients. That's the real question here, to be honest.
After you wired it, did you have a lot of residual thrombus after you wired it? Obviously, the OCT showed some thrombus.
No, actually. No, after we put the stent, the artery was great.
Because I guess before the stent, the question is if you just dilated it at low pressures with a smaller size balloon just to improve flow, and
Yes.
then, like you said, with GPIs or something.
Before the stenting.
And not stent it if there's no plaque rupture.
The flow was still very limited when we wired the artery. And we inflated the balloon, the flow was still very limited. It was open, but very limited. That's why we decided to proceed with stenting.
I think it's sometimes difficult when you're in that situation. I think we've all
Indeed.
probably experienced it through COVID, and it's hard when a patient is young to commit them to a stent too. So sometimes I've penumbraed, I've aspirated, I've done a lot of stuff to try to get the clot out. And if you can't restore that flow, maybe treating some with no reflow meds and going down that avenue. But if all else fails, sometimes I guess where hands are a little bit tied. But I agree, if there's ways or strategies to get around it without leaving metal behind, maybe that's best, but not always
Yes,
easy.
sure.
The other comment, fantastic case, by the way, and congratulations.
Thank you.
But the other comment is, while I definitely agree it's potentially a mechanism, the COVID, I do think that you need to consider the potential other etiologies for embolism, such as a paradoxical embolism. And I would definitely want to do an echo with a bubble study or some sort of assessment to make sure he doesn't have a shunt.
The echo study was normal in this patient.
Bubble, there's no
Yes,
shunt?
bubbles too.
And another little trick, this has happened a couple times in ectatic arteries with this heavy thrombus burden, where even your angiogenic, you can't get the thrombus removed, is considered intracoronary thrombolytics, even a low dose, 1 milligram, wait a few minutes, repeated. As low doses, 2 to 4 milligrams, I've seen a whole artery clear up within minutes, something to consider as well. And thank you so much. And sake of
Thank you.
time.
You could also use intracoronary GPI too.
Yeah, absolutely.
Thank you very much.
So we'll move on to our second case, Dr. Andrew Hill, a kink in diagnostic coronary angiography when radial access becomes complicated.
All right, thank you. Yeah, my name's Andrew Hill. I'm one of the third-year general fellows at Hospital Center in DC, but I actually submitted my application interventional this week, so looking forward to that process. Let's see. So starting with our case, we have a 61-year-old female. She does have some history of cardiac disease, a prior stent 9 years ago, and some other comorbidities. But the reason for this presentation was related to diverticulosis, which had been significant with prior GI bleed, and planned for a laparoscopic small bowel resection, which she had here in the hospital, as well as sigmoidectomy after recurrent episodes and small bowel obstruction. However, afterwards, she not only developed a postoperative troponin elevation, but she also had chest pain too. And so in the setting of that, we took her to the lab for diagnostic coronary angiography. She does have CKD at baseline, and her kidney function was a little bit more abnormal than her baseline here too. So we just started with simple 6-French right radial access. However, as we began to advance, noticed some resistance at the subclavian artery, and tried some simple maneuvers at first, switched wires. When that wasn't working, we had been really hesitant to inject or image because of the want to use low contrast, and so we tried to advance just with a pigtail catheter, which again, this didn't work. And eventually said, okay, fine, well, let's take a look and see what we're working with. And you can see here there's a significant subclavian loop there in the artery. So what to do next. Unfortunately, we had some aggressive catheter manipulation, which led to a kinked pigtail catheter. Not only really a kinked pigtail catheter, was doubled back over on itself, which I'll show in the next couple slides. And so what do? We tried simple catheter manipulation. We tried various wires. We tried stiffer wires. There was some concern too, like at the level of the kink, that we could perhaps protrude or poke out there, which we wouldn't want to do. And we couldn't really attempt external fixation since it was kind of at the level of the clavicle almost. And then so we decided to go ahead and proceed with right femoral artery access with an attempt to snare the catheter from the other side. However, we were unable to get under and over, so from the femoral, not able to cross the loop to get back to the radial. We could wire, but couldn't advance anything beyond. And so, well, then what do you do really at that point? So we decided to cut the end of the radial sheath, cut the end of the pigtail catheter, and then over that, encase it with a larger destination sheath. You can see here advancing, imaging up the arm, and moving forward here. At this point, we're about an hour and a half to 2 hours in, and of course, it's like 5 p.m. on a Thursday or Friday, whenever it was. And so this next image was particularly satisfactory at that standpoint. So what do you do in this scenario? This is from our group published a couple of years ago. I know Dr. Blakis and others have also talked about their algorithm for catheter kinking. So simple things first, untwisting the knot, trying external fixation, for example, is if it is more distal in the arm, perhaps connecting to an deflator and slowly increasing the pressure. That probably wouldn't have worked in our scenario due to the severity of the kink. And then either the idea of snaring or encasing with a larger sheath, and we had tried to snare first and then went with the larger sheath later. So just the rest of the case, Dr. Bindor uses rotational angiography. She does have ISR in her stent on the RCA and serial discrete lesions. They're probably 80–90% or so. However, with everything else going on in her acute illness in the hospital, decided just to manage medically for now and bring her back later on if needed for symptoms and intervention. I usually try and look at CTs and stuff beforehand if possible, just because there's a lot of free information there. She didn't really have anything before our procedure. However, she had a study actually the next day for a different concern. There was concern for bowel ischemia, and it didn't quite catch the full size of the neck. But perhaps you can see here as we go up the arch, and then I'll go back and forth a couple times, how significant really that loop is there. And, you know, honestly, would I have caught this if I looked on the CT? No, probably not. But then also, would it have changed my management? I don't know. I mean, I think a lot of times people, they see a loop, they still try and go radial anyways. But is that something that you should do more so, you know, or should we start at left radial or something like that instead? And so really my takeaways were number one, patients. You know, even though it is 5 p.m. or whatever time it was, we obviously caused a lot more problems by trying to be aggressive, manipulating the catheter, that sort of thing. These known algorithms, kind of approaching everything methodically. You know, throughout the case, there might have been 3 different attendings scrubbed in, and that's always helpful, I think, to seek opinions from other. And then the last point, which I would be interested, of course, to hear you guys' opinion on too, is we do have a couple older femoral stalwarts still in our lab, and I think the decision point of, well, when should you just, especially for diagnostic coronary angiography, just switch to femoral? You know, if the risk is not really there, should we have been taking a pigtail catheter up the radial, or should at that point, you know, we're 15 minutes in and just decide to get alternative access and prevent, you know, some sort of complication? We were lucky this went well. Of course, we could have had rupture of the subclavian aorta. We could have broken off the tip of the pigtail catheter. Something else much worse could have happened. So those were my thoughts. Thank you.
Excellent case. Great case, thank you. I think anytime I'm a big fan of radial. I think we're probably all big fans of radial, but sometimes the radial is just not our friend in a case. But that was good triaging. It's always nice when you have a group of partners that are collegial and will help each other out in those sort of situations. On the panel, any other ideas that how they could have triaged that or gotten the catheter out?
Actually, question before ideas. What size destination sheet did you use?
I think it was an 8, but I'm not sure. Yeah.
So I presented a webinar for CVI years ago where it's important to know that the OD of a destination sheath isn't the ID, and using a 6-French sheath to do an endovascular procedure actually caused intussusception of the radial artery. So I'm awesome that you guys got out of this because it was tough, but I would be really scared in hindsight to use an 8-French destination sheath through the wrist, especially in a vasculopathic patient.
What size was the pigtail?
Just a regular, like 5-French pigtail.
5 French.
Andrew, that was a fantastic case, and I love the end, the way you brought up all of the different points. And I think it's really important to reach out to others for help. That's important. But I think that one thing you always have to be careful about, and obviously this is, I don't know, but just like you said, whenever you're turning your catheter, you absolutely need to be sure that you see one-to-one response. So if you're torquing your catheter outside of the body, you need to be sure that you're seeing that catheter torque. And it's hard as an attending because we can't tell what you guys are doing. And oftentimes I'm like, speak up and tell me what you do. You know, are you turning it, or is it just not moving? You're not turning it. But we can see it's not moving. I can't tell if you're not turning it. So really important to make sure you see that one-to-one torque, so to avoid that. And then sometimes you can use a small coronary wire to get through, Or the other way around, before you even have this tortuosity, I oftentimes park. I wouldn't park a pigtail, so I'd take a right 4 because I think it's a better angled or straighter catheter, and then use a very small caliber, like a 4 French, and then use a coronary wire, get the coronary wire to overcome that loop. Then you can bring your catheter because it's a small catheter, and then after that change out for a stiffer wire.
But yeah, I think that also begs my last question. Well, then am I even going to be able to access the coronaries at that point too? But
just a question for the panel. When do you guys give your heparin when you do radial? The reason I bring this up is cases like this, I tend to get access, see if I can get to the root in a timely fashion, and then I give the heparin. I'll have the nurses give the heparin. In case you have to hit the go to femoral artery, because if you're using the higher 70 units plus per unit per kilo. Just out of curiosity, I have other partners actually give it in the radial cocktail right up front, and you're sticking potentially growing on full heparin. Just your thoughts.
I think that brings up a great point. Typically, we wait to see to make sure we can get past the aortic arch down to the ascending aorta before we decide to give our diagnostic heparin to start. But that's a good point. We do have some partners that will give just 2,000 of heparin, just initially through the radial. That's just their preference. They think that's low enough dose in case they need to switch to femoral. They're not fully heparinized at that point.
Great. Well, we're going to, excellent case. Thank you. So we're going to move on to our third case. Is Dr. Matthew Bruner here? Okay, so you want to move on to 910. Sure. A case of very late stent thrombosis in a patient with COVID. Dr. Kalampoki, did I mispronounce that? And I should know that because my background is Greek.
Good morning.
Good morning.
Thank you. Good morning. My name is Kalampoki Evangelia, and I'm a cardiology resident. I'm going to present you a case of a very late stent thrombosis. And we're talking about a male of 65-year-old with history of diabetes type 2, atrial fibrillation, hypertension, hyperlipidemia, chronic kidney disease, and he's also heterozygous in genoform kystinemia. As far as his previous coronary interventions, in 2018 he had PCI in LAD and NCA. In 2021, due to anterior STEMI, he had PCI to left main, LAD and LCX. And in this year, we found out that he had a CTO in RCA, which was treated successfully 1 year later. He brings an ICD because of HFrEF, and 2 years ago he had mitral because of severe MR. He's been treated with clopidogrel and apixaban, along with his medication about HFrEF. So the patient presented to the emergency department with acute pulmonary edema and anterior wall STEMI. The significant about the patient is that 15 days earlier, he turned positive on coronavirus and he'd been treated with remdesivir and corticosteroids, along with his supporting therapy. As far as his echo study, he has a left vertical ejection fraction about 30%, with scar of apex, septum, and inferior wall, moderate to severe MR, and also high risk for pulmonary hypertension. He had a loading dose of ACE and clopidogrel and transferred to the cath lab. Coronary angiography revealed thrombosis in a LAD stent in an aneurysmatic area of the artery, severe stenosis in a marginal brand, while previous stents in left main, LCA, and LCX maintain a good angiography result. This is the final result in PCI and LAD. And in the left image, we see the final result in PCI in LAD in 2018. And in the right video, we see the final result in LAD in 2021. I just want to show that the aneurysmatic area already existed. Following, we had an OCT imaging that revealed stent malposition in the aneurysmatic area of the LAD stent with severe amount of intraluminal thrombus. So we used a drug-eluting balloon. And also, the patient was administered to B3A, both as bolus as a 24-hour infusion, in a view of a large thrombus burden. And 4 days later, we had a new OCT imaging that revealed a reduction of the thrombus burden, but still some malposition. And we used a bigger drug-eluting balloon with a good final angiography result, a final OCT image revealed. After that, the patient was treated with triple antithrombotic treatment for 1 month, following dual antithrombotic with clopidogrel and apixaban, and his medication about HFrEF was titrated too by adding an ARNI. So I present a case of a very late stent thrombosis in a HFrEF patient with SARS-CoV-2 due to stent malposition and excessive thrombosis, possibly due to coronavirus infection and hemocysteinemia history. Stent thrombosis is a rare but usually catastrophic event, frequently associated with large myocardial infarction or death, with a relatively low estimated rate, varying between 1 to 4%. SARS-CoV-2 infection activates inflammatory mechanisms that potentially create a prothrombotic environment and increases the risk of local microthromboembolism and all types of stent thrombosis. New studies and registers show that the percentage of stent thrombosis increased during the COVID-19 pandemic, even up to 8 to 21%. This is my references. Thank you for your attention.
Thank you for that excellent case. Just a quick question before we get to the panel. When you first saw the angiogram and the stent thrombosis, I'm sorry I missed that. Before you did the 2B3 infusion for 24 hours, did you treat with anything in the cath lab, balloon angio?
No, he just had the clopidogrel and ASA, nothing more.
Okay,
yes.
thank you. Just to turn it over to the panel, just the way you may have managed that case in the cath lab, and actually we have a new panel on the end. If you want to introduce yourself and let us know where you're from, yeah.
Yeah, hi, my name is Manoj Kaswani. I'm an interventional cardiologist over at UC Davis. I was just going to mention that I think this case, in my mind, brings up the use of aspiration thrombectomy catheters and whether this would be appropriate in this case to use. Obviously, we have a lot of randomized control data suggesting routine use is not really appropriate, but we really switched to the use of the penumbra system in particular to have mechanical power aspiration thrombectomy. I wonder if that might really help decrease the thrombus burden. Another approach sometimes that we use is we think about different types of stents in this scenario. There's no data to support this, but sometimes we'll think about using the Medtronic stent platform because of the sinusoidal design, more likelihood perhaps to trap thrombus so there's not distal embolization. And that might be a way that we might approach this slightly different than what was done here.
Excellent tips. And yep.
I didn't see the angiogram before the wire. Was it like after you wired it, was it completely thrombotic besides the OCT showing thrombus?
It was the first one before the first deb that we used. We had the deb and then we had the OCT imaging, and there we saw the big thrombus burden.
Got it. Yeah, I mean, I agree that there's definitely some benefit to thrombus aspiration. I think that you have to obviously be careful in the caveats of the potential for dislodgement of the thrombus, particularly a large thrombus. And I think if you are to do that, you definitely want to be careful about continual aspiration until you get to the TUI and then stop aspirating as you're pulling it out of the TUI. And just be very careful to deep seat your guide so it doesn't potentially, you don't get thrombus on the edge of your guide and embolize distally or embolize to the rest of the body. I wonder if I would have perhaps maybe considered just ballooning it again and then reassessing it or just doing what you needed to do at that time. I think it depends on the degree of thrombus and how much after the initial ballooning you have, and I didn't get a sense of that.
I think a really critical part of this case was the imaging use. When we have vessels that are ectatic or aneurysmal, it's always so important that we try to optimize the stent the best we can, and it's really almost impossible to do that without either OCT or HDI vest. But so I really applaud you on that. That patient did get multiple runs of OCT.
It's also interesting. I mean, early in 2020 and 2021, often patients who were ill with COVID were systemically anticoagulated when they're in the hospital, and it seemed as COVID became less virulent that this went away, but it kind of shows us that that may not be the case.
Excellent.
Thank you.
Thank you.
Our next presentation, are we good to go back on track? Can we have Dr. Matthew Bruner come up, wishing percutaneous intervention options of enlarging anastomosis of vein graft to the aorta? Wayne.
Thank you. Sorry, I had some issues getting this uploaded here. We'll get started. Okay, perfect. All right, I'm Dr. Bruner. I have no disclosures. For our case presentation, I have a 66-year-old who presented to an outside hospital with complaints of chest pain and dyspnea. CT was obtained in the outside hospital, and there was concern for an ascending aortic aneurysm versus pseudoaneurysm of his vein graft, and he was transferred for evaluation by CT surgery. He has a known history of coronary disease, had a 3-vessel CABG in '98, and had multiple PCIs of his LAD in 2012. When he came to us, he was chest pain-free, although on an esmolol drip that was being down-titrated. He has a history of COPD and daily vape usage, and so he said he had some dyspnea, but nothing outside of his norm. We obtained the CT images, and it thought that his aneurysms were chronic rather than acute, and so we were consulted for catheterization. We'll go through the CT. They noted that the individual had a 6 centimeter by 8 centimeter by 6 centimeter, or 6 by 8 centimeter aneurysm, potentially filled by plaque and thrombus, and nothing that suggests rupture. And we see his abnormal CT images. Presenting EKG is nothing specific. On his initial echoes, relatively preserved function, some thought inferior lateral hypokinesis. Then we get to his angiogram. Left main looked like it had some disease and some proximal LAD. The circ was thought to be occluded. The right was a non-dominant vessel. His lima was patent to his LAD with what we thought to be an approximately 50% lesion there in the mid portion or the distal portion of the LAD. And this is his vein graft to his OM, which appears to also fill the left PDA. His vein graft to his RCA was known to be occluded, and so we deferred angiography at that time. He had progressive chest pain. He had a large aneurysm for his previous placed vein graft. We were deciding whether or not there were any percutaneous options or if open repair was the only way to fix this individual. After discussions between us, CT surgery, vascular surgery, we essentially said that we discussed occluder devices, but we didn't know the status of his tissue, and we didn't think that there was a good place to land it from the aorta to the anastomosis, and so we decided to recommend open repair with CT surgery. When they took him to the operating room, they incised his pseudoaneurysm and found almost a purulent fluid, sent for cultures. Same thing in the second lobe of his pseudoaneurysm, and he underwent patch repair as well as interposition graft to the lima. Unfortunately, the patient, once he was ventilated, was noted to have hemoptysis, had massive transfusion protocol, and we put him on VA ECMO. He continued to have incredible output and received units. He developed progressive acidosis, continued coagulopathy, and multi-system organ failure despite increasing support in ECMO, and the family ultimately decided to withdraw care. And so our thought was whether or not there were any other opportunities for percutaneous intervention in this individual, and if so, we didn't really have an idea as to what could have worked best to potentially stabilize this individual. Thank you.
That's a rough one. I don't know. I'm interested across the. Have anybody had cases similar to this?
I actually had a similar case several years ago, and it was presented in this meeting. This is a good vascular plaque case, actually. It was an RCA, SVG to RCA pseudoaneurysm with the same size. and AVP2 plugs fit pretty good there. And
What do you feel, though, of the use of plugs in bacteria? Because this thing was infectious, which most pseudos are, and that would make me super, super, super nervous about putting an endovascular device in.
that's an excellent point. I would exclude the ongoing infection for sure.
Is it possible to replay that slide with the graft? Our AV team back there? Oh, thank you. Appreciate that. I'm curious if, in the event that it's not infectious, where would the best place to put the occluder devices be?
We'll get, there it is.
So my suggestion is to go with an 8 French system with an 8 French guide liner or trap liner. And if you show the,
Let me see if I can go back.
Play that in?
Okay.
so it has a good neck of the pseudoaneurysm. Obviously, we are excluding the infectious etiology, but through, I would get there with a, I would inchworm the trap liner into the aneurysm sac and then deploy the plug through that, actually. So by using a coronary balloon, get into the aneurysm sac and then walk your trap liner or obviously a guide liner 8 French into that neck and then start deploying the AVP2 plug there.
I just have a comment. I commend you for presenting this case. Oftentimes, we get these cases where we have good successes, and it's not easy to come and present a case that the outcome isn't always the best. And I think you presented on a great day because we had a panelist who has experience with this. So just to commend you on that point.
Thank you.
Also, we have to justify the indication here. So my case was expanding aneurysm. So make sure you look at the prior CTs. If it's, I mean, your aneurysm was already halfway thrombosed, so we need to make sure it was expanding and we have clear indication to treat this patient.
So our, we didn't have the angiograms from previously. They were done at another hospital. We did have a report that said that he did have an ectatic or aneurysmal graft back in 2016 when he underwent a previous cath, but we had no frame of reference from any of their notes as to what that may have measured or whether or not this was enlarging. And so
most of these patients have like prior CTs, chest CTs for other reasons. This guy has COPD. I'm sure he had ER presentations and had a CT, so you could compare them.
yes, sir. Thank you.
I think that one other teaching point is, seeing pseudoaneurysms in the thoracic aorta or post-surgery or with thoracic endografts, barring somebody had a dissection or something in the course, these are almost always infectious. And it always goes through this realm where surgeons don't want to reoperate because they know the operative mortality is super high. But if there's any way at all to rule out infection, because no one ever, aside from Chevron, sees this, right? We've never seen an aneurysm at anastomosis that looks like that, so they're almost always infectious.
Excellent, thank you.
Thank you.
I was asked to ask the group here if you've all given your presentations to our team in the back. If you haven't, to please do so. And then the other thing too is the screen up here went blank for the comments that you're sending. Do you have the password? You want to say it out loud for everybody? What is it? 1313. Oh, excellent. Okay, thank you. All right, so just, if you can just hand your presentations in the back if you haven't uploaded them yet. So are we good to continue for the 9 o'clock spot?
I do not have the 9 o'clock, so we can go to the 9:20.
Excellent, okay.
9 o'clock is in here. You can come back here and you can.
All right, well, we'll start with 9:20. Dr. Ahmad Abdelhamid is going to present the dear price to salvage a catastrophe. Thank you.
Thank you for having me. Okay, I have no disclosures. My patient is a 70-year-old lady, type 2 diabetes, hypertension, long history of ischemic heart disease, mainly of chronic coronary syndromes and anti-ischemic therapies. 3 months before my story, she had non-ST elevation myocardial infarction, underwent coronary angiography that revealed complex coronary anatomy. Starting, there was a hazy that was the presumable culprit lesion in the proximal circ that received 1 DES. While the LAD has heavily calcified mid-segment CTO that fills primarily retrogradely from an RV branch, and the RCA has a proximal lesion, severe, then a CTO just distal to that RV branch origin. The lady, after revascularizing the culprit lesion, was advised for CABG for total revasc, but she absolutely refused, and hence she was scheduled for completion of revascularization by staged PCI. She had normal lapse and borderline normal ejection fraction. This was the setup for our procedure. And with the dual injection, the RCA CTO appeared to be kind of a shortish straight segment, more or less around 20 millimeters of length. And that was encouraging to proceed with the RCA CTO. And obviously, this was a clean shot into the right coronary artery, revealing the predominant filling of the whole LAD and the diagonal system from that RV branch just immediately before the side of CTO. We started with antegrade wide escalation. That was a turnpike LB, a fielder XTA that was extending in the vessel architecture, but was not sure if it is targeting into the distal true side branch or subintimal. So I changed into a guy second that was better torqued into the distal true lumen as confirmed in several projections. However, I had some difficulty in advancing the turnpike, so I had to advance the guy second to a distal position into the PDA in order to give me the support to be able to advance the turnpike LP into the distal true lumen. Hence, we exchanged with a workhorse wire, dilated the CTO, and that was the result after dilation. In the mid-right, despite I did not appreciate a heavy calcium, but this behavior of longitudinal clear-cut dissection gave me the impression that there might be some calcifications in that spot that I did not appreciate. However, with this result after dilation, we anticipated that we are a few minutes to finish, so I planned to land pre-bifurcation distally with a stent, overlap to the mid-RCA, but I have to respect the RV origin and make appropriate sizing to avoid to overlap with the stents over its origin and ensure to perform a good pot proximal to its origin, and may consider a DCP to the PDA accordingly. And accordingly, we proceeded with this exact strategy. We implanted the first 275/28 DS stent in LAO caudal. And then with the same 28 length balloon, I started to dilate and appreciate the length. And I planned to get another 3/28 zines that would land overlapping with the first stent, and proximally it will be a few millimeters distal to the origin of the RV branch. When we were deploying it, we noticed that its belly expanded more than the peripheries in strange fashion, and the patient yelled of chest pain. Without removing the balloon, I gave a small check injection, and we had that extensive staining. So probably the calcifications played here a nasty role and induced some media injury substent that led to dye extravasation. Immediately, the 328 balloon was inflated proximally to occlude flow. Echo ensured minimal rim, no chamber compression. The hemodynamics were excellent, stable. Actually, the blood pressure rose with the chest pain to 201/10, and I was taking it down with nitrates and IV morphine. I hoped that it closes conservatively, and so we opt for repeated cycles of long inflations, transient, deflate, and quick check for 5-6 minutes intervals. Repeated cycles, maybe for more than 25 minutes, but this did not work. So because a covered stent in this spot will be a very bizarre decision, we went to buy time. I tried to make use of the access that was in the left system to deliver it into the RCA, so I have two systems to deliver the covered balloon. However, the BMW was buckling, and this was taking a lot of time, and I realized that the graft master, the 3.5 graft master, is my available stent, and this is not compatible with a 6 French delivery. So we switched to the faster technique of advancing the graft master, removing the balloon, the occluded the balloon, and deliver the graft master, and making sure that it will cover the tear without occluding the RV origin. And that was the case. However, after deploying the graft master, the leakage did not shut. I was pretty sure that I have covered that site of injury. So we went to the proximal and the distal edges, overinflating them into high pressures. I know that graft master is not readily dilatable, but occasionally this trick works to overinflate the edges and make better vessel contact. But this absolutely did not work this time. So we plan to give another attempt of lung inflations, hoping that the residual spillage can go out with conservative management. And meanwhile, we started to think thoroughly to address the problem. I had an extravasation substent medial tear. I put a graft master or a covered stent. The staining or the spillage got reduced but did not vanish. So absolutely, it will not be able to be coming through the covered stent. Probably it is leaking from either above the proximal edge or from underneath the lower edge. But I had to know which edge is the culprit edge. And hence, if the vessel wall, and I put the graft master and ensured that it is in contact, it will contact, so the only mechanism potential to lead to this extravasation that I have multiple tears in the media, allowing for the spillage through the wall of the vessel to the site of injury, and hence the extravasation. So the difficult decision will be that I may be in need to overlap with another covered stent into one of those edges. But a critical question, which edge is the culprit edge? And more importantly, what if it was the proximal edge, because this will shut the RV and shut it for good. So to address this critical question, I inflated the balloon overlapping with the distal edge, so to ensure that there is no dye spilling distal to the stent. And with a very small injection, when I realized that the extravasation is spilling a lot of it, so this will make my proximal stent edge, which is the worst scenario, but this is the culprit one. Another long attempt, hoping and praying that it shuts by itself, but actually it did not work. But now I give it a longer cycle, ensured with echo that there is no chest pain, the hemodynamics was very stable, and things seemed reassuring. Obviously, delivering another graft master into the first graft master would have been impossible, mission impossible, so I inchwormed a guide liner. Now delivered the second graft master, optimized it, and have removed the RV wire. Now I have deployed it. And now we have seen that the extravasation is becoming very obedient. The staining has been fixed, so there is no more washing. The last part of the procedure was to proceed with stenting into the right coronary artery with the ostial flaring at 20 atmospheres, and that was the final result. After each step, I waited several minutes and take another shot in a different projection to ensure that the staining have been fixed, no more washing with blood in between sinews. And this is a plane without contrast to ensure that the staining has been taking the same behavior, which means that it has been shot in the vessel wall. without any new extravasation. And the most thankful finding to see that we, after recanalizing the right coronary, we had the birth of some BDA to LAD collaterals substituting the jailed RV branch. Through the hospital course, the echo repeatedly was ensuring stable, limited rim of effusion without chamber compression. Also, the ejection fraction was unaffected. From the next day post-procedure, the patient received loading of ticagrelor followed by maintenance dose every 12 hours, hoping to maximize the vessel patency. She was discharged safely after 2 days. The lessons we have learned, all the team have learned from the case that hand calcifications are a real enemy that can lead to troublesome complications. Incidence of coronary perforations is certainly proportional with the complexity of coronary interventions, and coronary interdependence can make any decision a tough one because sacrifices can be of very dear price. And the deep understanding, reconstructive thinking are always the way that help to defeat big challenges. Thank you.
Thank you for presenting that. That's so many teaching points in that case presentation. We are over a minute over, but just to make a couple of comments. One is utilization of imaging throughout your procedure. Perhaps maybe would have elucidated some of the calcium prior to stenting, and then always going into a PCI, when you're picking your equipment, and make sure your covered stents are compatible with your guides. And that's something that I routinely do because I've gotten stuck in the past where the cover stent didn't fit. So I always keep that in mind. We're going to move on. Excellent presentation. Just for the sake of time, because we're 2 minutes behind schedule. Thank you once again. Great presentation.
Is Dr. Chintan Patel here? Perfect. You can come on up and present to us first in human use of cerebral flow diverting stent in a large coronary aneurysm.
All right, thank you so much for having me. Thank you for the opportunity to present this case. So I'm coming in from Scottsdale where it's nice and hot, and so I appreciate the cool weather here. I've got no relevant financial disclosures. This is a case of a 58-year-old gentleman who presented to my clinic at the end of August with typical anginal chest pain, working at Home Depot, history of hyperlipidemia, uncontrolled hypertension, and very just classical symptoms. Baseline EKG looked pretty good. Eventually, a workup led to the cath lab. That's why we're here. This is just his non-dominant, pitiful little RCA. And for whatever non-dominance it made up, that the RCA had, the left circumflex certainly made up for it. So you see a large fusiform circumflex, mid-circumflex artery in a dominant system supplying a large OM1 and then an even larger LPDA. With a OM1 that's more proximal to it, there's some proximal LAD disease, which I was very thankful for because then it justifies sending him for bypass surgery. So a couple months later, he eventually got his bypass, 2-vessel bypass with a lima to LAD, vein graft to OM, a left atrial appendage clip. However, between November and February, started to have more progressive chest pain. Initially thought maybe this is just his sternal wound, but after that had healed, welled up, and his blood pressure was a little bit elevated. We tried to treat his blood pressure a little bit better, got a Lexus scan in February because bypasses can't fail that soon. And so we, with the normal Lexus scan, we continued medical treatment. We had no overt or objective evidence to take into the cath lab. So he decided to bring his own objective evidence with an inferior STEMI. And so in June 7th, 2023, he came in, inferior STEMI, severe chest discomfort. And so he got treated by a partner of mine. It was, of course, in the middle of the night. My partner thanked me for such a great case to have to wonder what to do with this, and ended up doing a POBA just to try to restore flow, intracoronary 2B3A along with an 18-hour drip of integralin. And now you can also notice that there's no real competitive flow down the LAD, so what's going on with that lima? These are the non-culprit pictures. He's got a great vein graft. However, the vein graft's going to the proximal OM. So what's being supplied distally is still the native flow through the aneurysm, through all that turbulence. The lima is a bridge to nowhere, and the right remains pitiful. So he had a femoral pseudoaneurysm for the STEMI that he had had. We had talked about treating the LAD. He was chest pain-free after 2B3A. He was started on Xarelto. We talked to him about treating the LAD while he was there. He said, let's wait a couple weeks, get him time to cool down, which made sense. And his EKG resolved. So we took him for an outpatient PCI of the LAD to at least, and this is after IFR and FFR confirmed that the prox LAD was significant. We ended up treating with good imaging-guided practices, a prox LAD with coronary lithotripsy. I opted to leave that mid to distal LAD alone. Treating those apical LADs was not the best thing, and he was doing fine with just this treatment. But the question still came up, what do we do with this aneurysm? You see that it's an aneurysm that ends in a 90% calcific lesion at a bifurcation, so you've got turbulent flow that ends in a stenosis. You're going to have thrombus potentially form. Now, granted, he's on aspirin, Plavix, and Xarelto at this point. So this is where the challenge presents. So what do we do? And right now, he's chest pain-free. So is there any percutaneous option that's out there? Well, we talked about covered stents and the problem is not indicated, and on top of that, you might lose a branch that might be significant for him. Do we just do medicine? Do dual antiplatelet therapy with anticoagulation? Is a single antiplatelet therapy with anticoagulation? What about the bleeding risk, warfarin, Xarelto, Eliquis? Literature is all case-based, so it's hard to tell what the right answer is. And then again, with the covered stent scenario too, what about size restriction? That's a big vessel and a long aneurysm. So what do we do? So we thought outside the box, and I had the pleasure of working in Tucson next to an interventional lab where we had an interventional neurosurgery where this is what he does all day. He treats cerebral aneurysms, and while our margin for error in the heart's low, theirs is even lower. So talking to him, they have these things called flow diverting stents, and the best analogy I could think of is if you think of our typical coronary stents being a chain link fence with those big holes in between, this is like a porch screen. So a lot more laminar flow through with a little bit porousness going through to the aneurysm itself, and the whole idea is to remodel. But it's never been done before. The extensive research has been looked at for case reports, talked to the companies, they've never done it, they've done it in mesenteric arteries. So it is approved to be used throughout the body. But the guy was doing okay. The design of the stent's not our typical one. This is 64 wires that are braided. So this is a self-expanding stent, not a balloon deliverable stent. However, it can go through a 6 French system, and oftentimes that's what they use for the cerebral world. And if you look at the bottom right, there's a lot bigger sizes. You can go from 2.5 to 5 millimeters in diameter with a length of 20 to 40 millimeters in length. So a little bit more range as opposed to some of the covered stents we have, and preserving side branch flow just based on fluid dynamics. Well, while we were thinking, the worst thing happened. He had another STEMI. This was only 6 days after the LAD intervention, and this is with compliance. Again, aspirin, Plavix, Xarelto. STs look even worse, and so does the coronary. And this is, again, a left-dominant system, so that right's not really contributing much. There's no collaterals going to this area. And so now what do we do? So he got his balloon angioplasty. He got his integralin again. He got better again. EF was still preserved despite all this. So we said we're going to go for it. And so, again, it's FDA approved throughout the body, so fortunately we had leeway to say that the heart's part of the body, so that works. And the hospital administration gave emergent approval for it as well. He stayed in-house. We kept him on heparin for about a week. And then the plan is to deliver this flow-diverting stent here. Now, with I had the neurosurgeon come up from Tucson, and we were there together, and there were 2 potential problems here. One is the actual length, but we solved that with we ended up using a 4.5 by 40 millimeters surpassive valve flow diverting stent, so the length is not a problem. But 2, the cardiac movement itself. This is not a stent that is designed to provide radial strength. So the amount of movement that was there could potentially kink this. So what we ended up doing was stenting from LPDA all the way back to the prox with traditional stents and put a 48 millimeter through the aneurysm, so it's floating in there to provide structural support. So this is the implantation after our traditional stenting with balloon angioplasty and coronary lithotripsy. you can start to see how this is tapering. We're actually removing it. And we ended up going radial for this. So 7 French radial. We ended up using some of the interventional toolboxes just to be able to deliver it because the system's a little bit bulky and our traditional coronary wires weren't doing it. As soon as we switched to their system, it looked great. It was able to deliver quite easily. So this is immediately after placement. You're still going to get flow through there. Remember, it's porous, so it's not going to be resolved. But here's 7 weeks later. And so you have some residual amount of the actual aneurysm, but this looks more like it. And heck, he didn't have another STEMI within 7 weeks, so that's pretty good too. The bar's low, but we surpassed it. That's 7 weeks later, so this is a little kind of putting it together where we started, what we treated, where we were at 7 weeks. And looking for any excuse to bring him back to see what it was, we were able to bring him back in 7 months. And now you just see this little pouch. I do feel bad for the next interventionalist who thinks that they perfed the vessel without even doing anything, because that's what it looks like. But it's a little neck of the aneurysm. It's the entrance of the aneurysm. And we could have fixed this better if we had put another flow diverting a little bit proximal. My interventional neurosurgical colleague says that this happens. It'll probably resolve within 2 years. But the patient, which is the most important part, was clinically doing great. He was able to participate in cardiac rehab. He was exercising every day. He had not felt this good since before the bypass. No longer having chest pain, ironically moved to Denver, so I'll be meeting him later on today too. So key learning points, again, this is the first time it's ever been done in a human for the percutaneous treatment of aneurysms. We don't have a lot of things. Oh, there's Mr. Law right now. He's the patient they actually we retreated. Thanks for coming in, Kelly. So the stents that we have we typically use for more structural support rather than, but we can think about stents for promoting laminar flow. I think that it's important to highlight the collaboration with other interventional partners. You know, there are other people that use wires, balloons, stents, and catheters, and they have a whole wealth of knowledge for their toolbox. And really, the only barriers to thinking about treatment is when you stop looking. So talking to people outside of your box is, I think, very helpful in that regard. Thank you so much. I'd like to point out that Jay Scott, this is the first time an interventional neurosurgeon was published in a cardiology paper. He was very thrilled about that.
That was excellent and great way to triage as well as discuss outside your comfort space with the interventional neurologist. So wonderful. Any comments from the panel?
I have a comment. So the issue with the flow diverters are they expand maximum of 5.4, and doing this case without any imaging will cause like a endo leak through that aneurysm.
So we did do imaging, I just didn't highlight it for the purpose of time. So after the initial deployment of the flow diverting, we did see what looked like a small little leak in that area. The maximum dilation for the flow diverting, and because it's self-expanding, was limited by the stent that we had placed over it. So we had put a 4 millimeter by 48 Boston Scientific Synergy stent, so it can't get any higher than that. So we basically recreated the pattern, the vessel itself. That is exactly what I think happened, is a small endo leak and what we're left with. Repeat CT imaging has shown that the aneurysm has actually shrunk in size. So it is something that we have to talk about, kind of continued surveillance, both clinically and potentially with imaging. But the fact that it's only getting smaller over time makes us feel pretty good about it.
A different approach to this case is putting a regular drug-eluting stent that we use and then put a coil through a microcatheter and coil the aneurysm sac, actually.
Yeah, no, I agree. We actually discussed that as a potential option too. There was 2 potential pitfalls with that. One is just the size of the amount of coils that we would have to use, and 2, the aneurysmal neck ended right near the bifurcation of that other of the large OM. So we were trying to preserve as much as possible. Given that there has been a proof of concept in the cerebral world, we thought we would try this, but our bailout would have been to potentially coil it. In fact, with this endo leak, that was the other next thought, that if we still have issues because the sac is smaller, we could probably just put a little coil through there.
One other question real quick, one that was awesome. in original surgery, although the aneurysm started in the AV groove, was there consideration for the surgeon to actually distally ligate the vessel prior to bypass so the aneurysm would actually shrink?
That was the hope,
its own?
to be honest with you. So when they said that we took care of it, I thought that they had taken care of it. And a little surprised that this kind of all happened. So we were hoping for a complete, either they would clip it or ligate it and then put a dedicated bypass in the LPDA or the OM2 to offer flow to the other vessel. So putting the bypass proximal actually made it worse. Yeah.
Okay, yep, go ahead. Sorry.
Sorry, that was a great case, and I have nothing to comment on what you did because it's way beyond my, I've never done that before, so fantastic work. One comment that I do have is the importance of, again, with STEMI in a giant aneurysm is just like what you did both times, restore the flow and then just discuss the options later. We're not here to try to stent in a STEMI in a giant aneurysm. First, the goal is to restore flow and just make sure the patient feels better.
Yeah, excellent point. And we want to thank you for showing up today and hope you're doing well. That's tremendous you're here joining us. We're going to move on. Are we going to go backtrack to 9 o'clock, or are we going to? Okay, that's fine. Then we'll continue at our 9:40 spot. Dr. Banerjee, acute MI and LVAD patients, role of coronary angiography. Thank you so much for presenting today.
Next. Thank you. Good morning. My interesting case is on acute MI and LVAD patients and the role of coronary angiography. Our first case is a 61-year-old male with a history of hypertension and coronary artery disease. He had known 100% proximal occlusion of his RCA and diffuse LAD disease and ischemic cardiomyopathy related to that. He had had a HeartMate 3 implantation and an aortic valve stitch 16 months prior to his presentation with substernal chest pain and associated dyspnea. His vitals on arrival were fairly stable. His labs were notable for an elevated troponin, BNP, creatinine, LDH. His lactate was normal, and his INR was subtherapeutic. His LVAD was interrogated with no low flow alarms, and notably, the patient had had an echocardiogram 1 month prior to his presentation, at which time it was noted that the aortic valve did not open, but the relationship between the LV and the RV was fairly acceptable, the septum was midline, and no changes were made to his device. Ultimately, the patient was taken to the cath lab, and the left main coronary artery was unable to be engaged with a JL4 catheter. The RCA was already occluded, and so pigtail angiography was done and showed extensive aortic root thrombus with occlusion of the left main coronary artery. A right heart cath was done to assess hemodynamics, which showed slightly elevated right-sided filling pressures, but all in all, the hemodynamics had seemed reasonable, and the patient was taken for additional echocardiography. The echo showed a large immobile echo density on the aortic root side of the aortic valve, measuring 1.8 by 2.5 centimeters, suggestive of thrombus. And this was confirmed on CT coronary angiography, which showed, again, a 3.1 by 2.9 centimeter clot on the aortic side of the aortic valve with complete obstruction of the left main coronary artery. The RCA ostium had been patent, but slightly narrow. And so all in all, this patient was actually just treated with therapeutic anticoagulation. He was treated with heparin while in the hospital, 10A goal of 0.3 to 0.7, and aspirin 325 milligrams. He was discharged on warfarin with an INR goal of 2 to 3 and the high-dose aspirin, and he received a heart transplant 4 months later with LVAD and ICD extraction. Our next case is a 30-year-old female with a history of quadriplegia and idiopathic dilated ischemic cardiomyopathy. She had a HeartMate 3 and tricuspid valve repair, PFO closure, and she had presented with her ICD firing 19 times for VF. She had had an elevated troponin when she arrived. Her echocardiogram was limited and bedside, but showed biventricular dysfunction with an LVEF of less than 20%. Ultimately, she was taken to the cath lab, and angiography showed clot in the left coronary cusp, due to which reason we were unable to engage the left main. The RCA was imaged, and angiographically was actually patent. And then once more, pigtail angiography showed occlusion of the left main coronary artery with retained contrast and filling defect consistent with clot. This patient was continued on systemic anticoagulation and discharged with outpatient follow-up. Unfortunately, she had passed away a couple of months later before obtaining additional cardiac imaging like a CT, additional imaging as well. And then our last patient is a 62-year-old female with a history of mitral valve replacement, also idiopathic stage D heart failure, had a HeartMate 2 as destination therapy, and a history of VT. This patient had suffered a subdural hematoma and had actually been off of anticoagulation and presented with recurrent ICD shocks for VF. Unfortunately, on the morning of presentation, the patient suffered a cardiac arrest. Bedside echocardiography showed nominal LV, EF, and RV dysfunction as well. And so ultimately, the patient was taken to the cath lab. Angiography showed incredibly slow coronary flow related to a thrombosis of the aortic root as well as the coronary arteries that was not amenable to PCI. Pigtail angiography once more showed occlusion of both the ostium of the right and left coronary arteries. And the LVAD outflow tract was demonstrated to be patent. Aortic root thrombus is a dreaded complication of continuous flow LVAD devices. Constant flow into the aortic root, coupled with reduced preload in the native LV, results in decreased excursion or complete closure of the aortic valve. And stasis of blood can form a nidus for clot formation and can lead to systemic embolization, stroke, and in these cases, acute MI from obstruction of coronary flow. Our suggested management of these patients when they present with acute MI in the setting of an LVAD is to obtain additional cardiac imaging, ideally a cardiac CT or at the very least a complete echocardiogram to assess for aortic root thrombus. So in the event that the patient goes to the lab, at least the operator has an idea of what they're dealing with. In the event that the patient is too unstable for additional imaging and goes straight to the lab, we would suggest pigtail angiography of the aortic root to assess for thrombus prior to attempting to engage the coronary and potentially propagating clot. And then lastly and notably, systemic anticoagulation is a successful therapeutic option for these patients if a bridge to transplant is feasible. Thank you.
Yeah, excellent 3 cases and great learning point for all of us who see LVAD patients. Were all 3 aortic valves, were they all oversewn in these patients? I know the first one was, I didn't catch the second or third one.
Yeah, great point. Only the first aortic valve was sewn, and as you know, that stitch in the aortic valve is associated with thrombus formation on the valve itself and not just the root. But the second and third actually weren't sewn. The third patient had been off of their Coumadin for a subdural hematoma.
Was there any follow-up imaging? I know one got transplanted prior to transplant. I know one passed away, but was there follow-up after being on anticoagulation to see if the thrombus resolved, and how long did it take?
Yeah, the first patient you're saying had resolution of their aortic root thrombus prior to transplant.
Okay. Interesting cases. It's, you know, we have a lot of LVAD patients, and I'm not sure if I've maybe heard of it once in the last decade, but I'm sure it happens more than we think, and I'm sure my partners have seen it. We just haven't talked about it. Any experience from the panel and any comments? Yeah, I think it's, go ahead.
I think it's always, it would make me a little anxious putting any sort of catheter down into the aortic root, knowing that much thrombus burden is there from some of the scans that were done previously. But I guess none of the patients ended up having any stroke or embolization after angiography.
Yeah, I mean, the last patient, you know, had a pretty unfortunate outcome. The second patient did not have any kind of like stroke or embolic event, but all in all, I think your point is well taken that the role of angiography in these patients is really probably quite limited because of the risk of systemic embolization and then also the likelihood that you would intervene on a lesion in a patient with an EF of less than 20% and non-ischemic cardiomyopathy to begin with. So exactly. Thank you.
And we will invite our last speaker up, Dr. Ibrahem, for Together We Make a Difference. Title, I like the title.
Good morning, everybody. Thank you for having me today. My case title is Together We Make a Difference. I have no disclosure. My patient was a 57 years old male patient, smoker and hypertensive. Patient presented with agonizing chest pain for 5 hours. Blood pressure was 170 over 100 millimeter mercury. No significant ECG changes, and ejection fraction was 50%, was mildly dilated aortic root. Cardiac enzymes were positive. So the patient, we think what's going on in this patient with chest pain This could be non-STEMI or aortic dissection, myocarditis, pericarditis, or non-cardiac chest pain. At the patient considered high risk for ischemic heart disease, at the male patient, 57 years old, and heavy smoker, hypertensive, we proceed with coronary angio. You can appreciate there is no significant coronary stenosis. So how to proceed? Managing the patient as Minoka and continue on antischemic medications, or ask for CT aortic angiography to exclude aortic dissection. Consider myocarditis or pericarditis, proceed with CMR and medical treatment, or searching for non-cardiac causes. As the team in Cath Lab, we decided to have a second look for the coronary angio, and that's what we found. You can see this staining beside the diagnostic catheter. Is that aortic dissection? And also in the left system, no significant lesions.
You're missing the circ?
Yes. A team member said, where is the circ? Yes. We look again for the left coronary system. You can see a long left main, and there is no circ in this view. So this could be the circ, which is totally occluded. Yes, it was anomalous LCX origin from the right coronary sinus. We proceeded with wiring and stenting. You can see it's very long LCX with a lot of branches. My take-home message, coronary artery anomaly is less than 1% of general population and have been identified as a common condition in young athletes with sudden cardiac death. Anomalous origin of left circumflex is usually considered a benign finding, as its course is almost always posterior to the aorta. Inadequate visualization and recognition of an anomalous LCX may pose challenges during revascularization, especially in primary PCI. When the first left angiographic view on angiogram show unusually long left main coronary artery, an anomalous origin of LCX should be considered. Every member in Cath Lab is a main player in the game. I want to finish with this quote for Henry Ford: coming together is the beginning, keeping together is progress, and working together is success. And thank you.
That's a wonderful case example of teamwork and finding out what the real diagnosis is. So well done, well done. Any comments from our panel?
This case also reminds me of the importance of a left ventriculogram, that oftentimes when patients present with an acute coronary syndrome, we don't see an obvious culprit, that a ventriculogram or even echocardiogram prior can really point out what the potential culprit could be. And so I just want to make that quick point quickly.
I just want to say that's a really great case, and I love the fact that you said the first step is to go back and look at the angiogram, because I think that that happens quite a bit, where it's been called Minoka, but you'll go back and look at the angiogram and you'll see a flush occlusion. So a really, really nice case of making sure you look at that angiogram again before you say
this
something.
patient could go out of Cath Lab with a totally occluded circ if we didn't revise the angiogram again.
Yeah, it's so important when you're looking at the angiogram where there's an area that's missing branches. I mean, it just something should alert you something's off, and that was clearly when we did the left, there was an area that didn't have any perfusion. So, yeah, taking the time and going back and looking is so important.
I like the way you said it's true. That happened to me once, actually. We were finishing the case, and somebody outside, either passing by or one of the nurses or technicians, was the one who said, well, something's strange there or whatnot. So it's so important to hear from your colleagues.
Yes.
Was that sometimes those are difficult to engage as well, depending on the takeoff, if it's coming off the right coronary or off the prox RCA. Was that a J4 guy that you
It was challenging, but we could manage with Judgment right.
Okay, yeah.
Thank you.
Really excellent cases from everyone who presented. Thank you so much. A lot of great teaching points, and I learned quite a few things, so I really appreciate everybody's time. Any final comments?
I think that was actually a great case to end on in the sense of teamwork, horizontal communication in your cath lab is super important so that people feel comfortable in that space to bring attention to different problems that may be going on that we don't recognize being at the table.
Thanks to our panel and your expertise and your comments. Thank you. Guys, enjoy your day.